Today we're going to be talking about whether Parkinson's and Lewy body disease are two peas in a pod, as I think Dr. Weintraub has called it. And I think in our description, we might have said two sides of the same disease. I know we have talked about Parkinson's disease dementia. We've talked about Lewy body disease. Or Lewy body dementia, and that can be often confusing for people. They seem very similar. They have similar presentations. They both present with Lewy body clumps in the brain. So we're going to be talking about, are they actually two different things? Are they the same? With Dr. Daniel Weintraub. So some of you may have seen Dr. Weintraub with us before. He is a geriatric psychiatrist and a professor of psychiatry at the University of Pennsylvania Institute of Aging. His expertise is in research, including the psychiatric and the cognitive complications of Parkinson's disease. He served on lots of different movement disorder societies, task forces, and he's working to revise and make recommendations for the assessment of and the importance of the non-motor symptoms in Parkinson's disease. And he did write an article about this very topic today, which is why he's here, because I felt like this is something that we all are very interested in to kind of help with some of this confusion. So he's going to be giving us a breakdown on why he feels the way he does about potentially unifying these two diseases. And so he does have some slides. I'm just going to let you guys know in advance, because Zoom occasionally does these updates and then we get these little glitches sometimes. You might notice a gray box at the top. We tried to get rid of it just before we brought everybody in from the waiting room. We played around with it. It doesn't want to go away. We can't seem to find any fixes for it, so we apologize in advance. I don't think it's going to obstruct anything that you're seeing, but we just wanted to let you know that in advance. But I want to welcome Dr. Weintraub, and I'm going to hand this over to him.
Thank you, Anissa and Pele and Reagan. Thank you for the invitation. Hello, everyone. I think Anissa's already introduced the topic, so we can just get started. I did want to say in advance that since we're discussing cognition, I know this is always a difficult topic, and I'm mindful of that, and I'll do the best to be sensitive in my presentation. And also, this is really, my opinion. I'm making a case here, and other people have other opinions. Some are similar to what I'm saying. Other people feel very differently. So I'll just try to make my case and support it the best I can. And there's, this was put together for an academic community, and I didn't want to really change the slides. So I'll try to just present it the best I can and explain it the best I can. And at the end, any questions and comments are welcome. So let me go ahead and share my screen, and I will share my presentation. And I will maybe ask Anissa if you can see this okay.
I can see it fine. There is a little box, but again, it's not obstructing the majority of your slides, so you're good.
Okay. So I will proceed then. And the title is Parkinson's Disease and Dementia with Lewy Bodies, two peas in a pod. And those are my affiliations below: University of Pennsylvania and the Philadelphia Department of Veterans Affairs. And by the way, I'm a psychiatrist, a geriatric psychiatrist by training, and my area of interest is the psychiatric and cognitive complications of Parkinson's disease. So my case really begins with saying that we have a problem, an untenable problem in my mind, because it's something that's been around for a long time and is not sustainable into the future. Some change has to occur, in my opinion. And this is really meant to kind of highlight the problem. This is a figure from a paper courtesy of Dr. Brad Bove, who's a dementia with Lewy bodies and sleep disorders expert. And what you see here is this assortment of clinical symptoms that are represented by colored circles that overlap in this kind of very complicated way. And really what this is meant to represent is Lewy body disease. And that Lewy body disease, I would make the case, could be Parkinson's disease, or it could be dementia with Lewy bodies, because these features are common across both disorders. But what is this figure? It's a Venn diagram from hell, because it's impossible to explain this to anyone in an interpretable way. And what I mean by that, it's impossible to explain how Parkinson's disease, particularly Parkinson's disease dementia, can easily be differentiated from dementia with Lewy bodies. And this is hard to explain to patients, to families, to clinicians who are treating patients, to researchers who are applying for funding and studying this, to funding agencies and foundations. So another example of the untenable problem is the nomenclature or nosology, the words that we actually use to describe these disorders. And there's just too many terms, and they're too confusing and too overlapping. So you have PD, which is Parkinson's disease, PDD, which is Parkinson's disease dementia, DLB, which is dementia with Lewy bodies, two types of LBD, Lewy body disorder, Lewy body disease, the latter being a pathological diagnosis, something on autopsy. And then these kind of more outdated neuropathological terms, Lewy body variant of Alzheimer's disease and pure Lewy body disease. And they have to do with the presence of coexisting Alzheimer's disease pathology. So what if you look at the clinical criteria, if you're actually seeing a patient and want to diagnose someone with existing consensus expert criteria? So these are the most recent criteria for dementia with Lewy bodies that were published 7 years ago or so now. And what you have for dementia with Lewy bodies is the essential feature is the presence of dementia. So that's significant cognitive impairment across multiple cognitive domains, as they're called. So things such as memory, attention, language, and so on. You have to be impaired in multiple domains. And then other hallmarks of DLB are fluctuations in alertness or attention and cognition, psychosis, particularly visual hallucinations, Parkinsonism, so those are the motor features of Parkinson's disease, and something called rapid eye movement sleep behavior disorder, or RBD. That's the physical and verbal acting out of dream behavior, dreams at night. And I put that in green because that's a recent addition to the diagnostic criteria, the most recent version. And what if you shift over to Parkinson's disease dementia? And I would make the case that the criteria for Parkinson's disease dementia are almost identical. So you have to have Parkinsonism due to your Parkinson's disease diagnosis, but then you also need to have dementia with impairment in multiple cognitive domains. And you often have other psychiatric features such as hallucinations are supporting the diagnosis. So there's very much overlap there. And it used to be, or still is, I would say, for many people, this what I would call a sacrosanct dividing line, which is called the 1-year rule. And that 1-year rule is that if you have Parkinson's disease for at least 1 year and then develop dementia, you would be diagnosed with Parkinson's disease dementia. But if that dementia came within 1 year of the diagnosis of Parkinson's disease, or even preceded it, then you really should be called dementia with Lewy bodies because your dementia came first. And that's been the traditional 1-year rule. But in the Parkinson's disease criteria, when its latest clinical criteria came out about a decade ago now, they didn't consider dementia as an exclusion criteria for Parkinson's disease, regardless of when it occurred. So you could have dementia first, then develop Parkinson's disease, and then in the eyes of the movement disorders criteria community, you would still be diagnosed with Parkinson's disease dementia. So now you could have the same person diagnosed as Parkinson's disease dementia by one community and dementia with Lewy bodies by another community. What about pre-dementia criteria? So as many of you may be aware, there's an interest in moving our assessment and diagnosis of patients as early as possible. So what's called the prodromal or at-risk state. or identifying people just on the basis of biology before they have clinical symptoms. The clinical criteria that exist for these stages are really using a lesser severity of cognitive impairment to diagnose patients. So basically, instead of saying they have dementia, we're now saying they have mild cognitive impairment, so an earlier stage of the cognitive decline. And let me present you a little more information about that. So we have research criteria from the Movement Disorder Society for what's called prodromal Parkinson's disease. So those are people that don't have a formal diagnosis of Parkinson's disease, but have these non-motor symptoms that I'm showing on the right that are early features of the Parkinson's disease before the motor symptoms. That includes that sleep disorder that I was talking about, the RBD, impaired smell, constipation, sleepiness, and psychiatric conditions such as depression and anxiety. The original criteria almost a decade ago did not include cognition, but subsequent to that, when this was updated almost 5 years later, due to ample additional research that showed that cognitive changes can occur in the prodromal state for those people who are destined to develop Parkinson's disease, cognition is now one of the criterion for prodromal Parkinson's disease. And then I'm illustrating some of the research that helps support that addition of cognition in prodromal Parkinson's disease. This was a study called the PARS study, or the Parkinson's Associated Risk Syndrome study, where they took patients, or not patients, community members who had impaired smell and had what's called a dopamine deficit on the basis of their dopamine transporter scan. That's what the scan looks like on the right when it's impaired. So that's a person with impaired smell with what's called DAT reduction on their scan versus normal DAT function. And if you look at those people who have trouble smelling and also have a dopamine deficit on their brain scan, but don't have a diagnosis of Parkinson's disease yet, you can detect cognitive differences across multiple cognitive domains compared with people that don't have these features. So what about MCI of DLB or MCI of Lewy body? So that's taking the dementia with Lewy body criteria and kind of fitting them for the earlier cognitive stage of mild cognitive impairment. So instead of having dementia, you now have mild cognitive impairment. You have these other features in the red boxes that were already a part of the dementia with Lewy body's criteria, so that hasn't changed. And the one thing I would add, though, is that if you have a positive dopamine transporter scan, I just mentioned that from the prodromal Parkinson's state, and that's in the green box, you only need one additional feature after mild cognitive impairment. So you could have a positive DAT scan, mild cognitive impairment, and some Parkinson's features, and you would meet the criteria for MCI of Lewy bodies, but you would also meet the criteria for prodromal Parkinson's disease as well. So again, showing the overlap between these two disorders. Some people have looked at existing databases to look at the clinical features prior to conversion to a diagnosis, in this case of dementia with Lewy bodies. This is called the NAC database, which stands for the National Alzheimer's Coordinating Center. And it's a data set that primarily includes Alzheimer's disease patients, but it includes some dementia with Lewy body patients and Parkinson's disease patients as well. In the years leading up to the time of a dementia with Lewy body's diagnosis, you see these high rates of neuropsychiatric features, nighttime behaviors, which very well could be that REM sleep behavior disorder I was telling you about before, anxiety and depression. So the very same kinds of features I already discussed for prodromal Parkinson's disease also exist in this prodromal dementia with Lewy body state as well. You also see high rates of Parkinsonism. So the same thing you would expect from somebody to develop Parkinson's disease, you would have these subtle signs of Parkinsonism in this group that's ultimately going to be diagnosed with dementia with Lewy bodies. It's just showing the overlap between these disorders once again. This idiopathic REM sleep behavior disorder is really fascinating, or isolated or idiopathic RBD. It has a near universal conversion to a Lewy body disorder over 15 or so years. But the fascinating part about this is that about half of the patients convert to a motor diagnosis of Parkinson's disease, and half of the patients convert to a cognitive or dementia diagnosis of dementia with Lewy bodies. So to me, starting from this very um, unified common point of an isolated RBD diagnosis, but progressing on two different tracks somehow really speaks about a single disease with variable course and presentation for reasons we don't really exactly understand yet, but not that they're actually different diseases because they started from the same place. And what about those people with isolated RBD who are destined to develop dementia with Lewy bodies? So if you convert to dementia versus Parkinsonism, you have impairment in these cognitive tests already in the prodromal state: attention, what are called executive function or abilities, visual spatial functions, and memory abilities. And those are the same cognitive domains that I showed you before from the PARS study that are also affected in prodromal Parkinson's disease. So it's really hard to differentiate the cognitive profile of dementia with Lewy bodies and Parkinson's disease, whether you're talking about late stage disease or here in this case, very early stage disease. So clinical presentation. So again, these are some of the kind of harder slides to present, that we know that dementia is common long-term in Parkinson's disease. Unfortunately, it's often takes many years for people, and it's as they get much older. So there's many people that live a long time with Parkinson's disease without significant cognitive changes. But eventually, most people do develop some significant cognitive impairment. So we know that. If you look at the actual cognitive profile in Parkinson's disease and DLB, I've already mentioned this, but they're really similar. It's just that the DLB patients tend to be more severe across the board than the Parkinson's disease dementia patients, but the profile seems to be similar. It's not really easily distinguished. What about other features, in this case, psychosis? So here you see more in common than dissimilar. So visual hallucinations or hallucinations broadly, delusions, which are fixed false beliefs, are relatively uncommon in Parkinson's patients without dementia. But as you develop dementia with Parkinson's disease, they become much more common. And as you then go to somebody who has DLB, it's even more common. So this exists on a continuum. It's not that psychosis is unique to either disorder. It's just that it's, once again, more common in DLB compared with Parkinson's dementia. We know now that hallucinations actually, or what are called minor hallucinations, can occur even in Parkinson's disease patients without exposure to medications at disease onset. So that really kind of ties Parkinson's disease and DLB together even closer, because we often assume that it's the medications in Parkinson's disease that are driving these hallucinations, as for example, but this is a case where people are not even being treated with Parkinson's medications yet. They're just diagnosed with Parkinson's disease for the first time, and yet they still are more likely to have these minor hallucinations than people without Parkinson's disease. Once you have established Parkinson's disease and dementia Lewy bodies, I was talking about this isolated RBD in the context of prodromal disease. But if you have established Parkinson's disease or dementia with Lewy bodies, these sleep disorders, RBD, are incredibly common, and amazingly so, almost identically common in both Parkinson's disease and dementia with Lewy bodies. So about 3/4 of patients will eventually develop this sleep problem. All right, so a little bit about what we call the neural substrate or neurobiology of these disorders. So the field has really been evolving significantly recently, and I'm sure many of you are aware of this, but our ability to actually detect what we call synuclein disease as while somebody's living, and that's happening through obtaining tissue. In this case, it's often cerebrospinal fluid from a lumbar puncture, but also skin as well, to detect what we call alpha-synuclein through this procedure called seed amplification assay. And what I just want to call your attention to is that the overwhelming majority of Parkinson's disease patients are positive, as are the overwhelming majority of DLD patients. So on the left, you have a clinical cohort using lumbar puncture. On the middle part, you have a pathology confirmed cohort, so people who went through autopsy that were confirmed to have PD and DLD. And then finally, on the right, you have skin as opposed to cerebral spinal fluid. But in all three cases, the rates of positivity of the synuclein test is very high for both PD and DLD, really confirming that these are both synuclein diseases. The other way we help diagnose Parkinson's disease from a biological standpoint is looking at the dopamine system, and that's typically done with what's called a DAT scan or a SPECT DAT scan or dopamine transporter scan. And that's really a measuring, again, the integrity of the dopamine system in the areas of the brain that are responsible for motor control. And here you can kind of see in the panel D that you see the loss of the signal for this dopamine transporter scan in somebody with Parkinson's disease. But what we know is that that kind of DAT scan deficit, as it's called, is positive not only in Parkinson's disease, but in dementia with Lewy bodies. It's very common, including in patients with autopsy-confirmed DLB. So I've presented data that the synuclein is similar for the two disorders, that dopamine transporter or dopamine system deficits are similar for the two disorders. And then if you look at autopsies or neuropathology, you see very similar findings as well. Again, the theme it continues here with DLB just having more severe and more widespread what's called Lewy body disease throughout the brain compared with Parkinson's disease dementia. So it's similar, but just more severe for the DLB patients. But if you look at the overall staging, as it's called, of the Lewy bodies based on something called the Brock staging system, it's actually quite similar for Parkinson's dementia and dementia with Lewy bodies. So what would differentiate these disorders clearly is not the presence of an inherent neurobiological process of synuclein disease, but comorbid Alzheimer's disease. So what I'm presenting here is looking at imaging scans, PET imaging scans measuring amyloid in the brain. And what you can see by going left to right, top to bottom, is that if you go from normal aging all the way down in the top left down to dementia with Lewy bodies in the bottom right, you're just getting more and more amyloid in the brain. So they almost seem to have as much as Alzheimer's disease patients, whereas Parkinson's disease patients has less, but those with dementia have more than those without dementia. So again, it's along a continuum. That's what the arrow is meant to represent. We know that if you look at pathology directly through autopsies, that the severity of Alzheimer's disease pathology correlates with the severity of Parkinson's disease pathology, with shorter time to dementia onset and to time to death. So this comorbid, as it's called, or co-occurring Alzheimer's disease pathology really seems to drive the clinical course to a great extent. So I'm going to finish up with the contention I have, which is that the differences between Parkinson's disease and dementia with Lewy bodies, I would say, are quantitative, but not qualitative. So it's a matter of degree as opposed to a difference you can point to, or you would say this disease is meaningfully different in some way from this other disease. Now, there are some reported differences in the bottom that I highlight. They might have to do with genetic differences or imaging differences or other things that have been reported in a neurobiological way. But again, I would say these are really more quantitative, but not pure qualitative differences that really points to a different disease process. So that's one conclusion. The other conclusion is that the differences are largely between the clinical syndromes of Parkinson's disease and dementia with Lewy bodies are really driven by age and comorbid Alzheimer's disease pathology. So we know that the mean onset of Parkinson's disease is in the low 60s, and the mean onset of dementia with Lewy bodies is more in the late 60s. And what happens as you get older is that you're more likely to have co-occurring Alzheimer's disease pathology. So I think that's partly explaining the differences that we see and offering some explanation for why the age of onset. So when I published an editorial that Anissa referred to, there was eventually a counter argument made, not to just what I was suggesting, but to the whole notion of diagnosing Parkinson's disease on a biological basis and staging it in a somewhat controversial way, maybe now. And part of that counter argument was published in a viewpoint, but it did address this specific issue of the implications of unifying Parkinson's disease and dementia with Lewy bodies, which is what I'm proposing. And they thought the implications are that it might have an impact on healthcare practice, research, and public health initiatives. They thought that focusing just on the dopamine system was a shortcoming because there's other neurotransmitter or chemical systems besides dopamine that are affected in Parkinson's disease and dementia of the bodies, and that's true. And that they felt that the proposal didn't delineate properly the boundaries of cognitive and functional standpoints as people progress across the stages of illness. So my thoughts about those 3 points, so the counter to the counter argument is that I do think its impact, these changes that are being proposed on standardized healthcare practice research and public health is important. But the clinical diagnoses of PD, PDD, DLB will be around for the foreseeable future. These are just research proposals, not for direct implementation in clinical care currently. And also that really science should drive the field forward. So not just worrying about impact on healthcare practice, but ultimately good science should drive things forward, and then healthcare policy should follow from that, I think. This neuronal synuclein disease definition that some of you may be aware of, but it's really based on this biology that I was talking about, synuclein and dopamine dysfunction, is modifiable. So of course, it's not just the dopamine system affected, but that's the system we can most easily and accurately assess at this point. So, but as other chemical systems or biological systems are implicated, they can be incorporated into future criterion. And then this thing about progression, I think we're really proposing that we want to start at the beginning, like before people develop dementia, before people even have mild cognitive impairment, but identifying them as early as possible with a common disease definition, synuclein, dopamine, for instance, and then following them forward to see how they progress. Like, why do some people progress more on a cognitive track versus a motor track? So a way forward, and these are the last few slides. So this was the viewpoint that again, I published it last fall, and so almost a year ago now, or approximately a year ago. So that given that PD and DLB are substantively the same, a single biological definition clinical staging system can and should encompass both disorders, from prodromal to late stage. I do believe that. The main sticking points are around terminology and territorial disputes. So nobody likes to give up their turf, their territory, and people have differing opinions about what terminology should be used. The group that I was a part of settled on neuronal synuclein disease. Other people have proposed other terminology. But to me, I think the most remarkable part of all of this is having been involved in research in this area for over 20 years now, and coming at this from very much a psychiatric and cognitive standpoint. As a psychiatrist, I'm not a neurologist, is that cognition in this new staging, disease definition and staging system, that cognition and other non-motor features, psychiatric features, are now on a par with the motor features when staging Parkinson's disease from its earliest stages. So if you have the biology of the disease, you don't have to have motor features. You could have cognitive features and you still have the same disease. And to me, that's really a remarkable, like transformation in how we think about these disorders. Parkinson's disease has always been such a motor-centric diagnosis and focus, and here we're talking about something quite different. So one possible solution, and is to have this unified terminology and staging, which has already been proposed. So I think keeping PD and DLB distinct may do more harm than good in the long term. Finding a terminology, unifying the disorders, but still recognizing differences in the onset of symptoms seems preferable to me. And you could basically clinically subtag once you have a biological diagnosis. So you could have synuclein disease Parkinsonism or synuclein disease cognition, dementia. You could have more than one over time. So the definition and staging should be able to accommodate this evolution of symptoms. It should be able to accommodate, as I said, multiple diagnoses over time, but also not to include Alzheimer's disease, which is really a distinct disease, that should be staged in its own way. Some people have proposed that you combine them, but to me, it anyway makes more sense to have a synuclein disease definition and staging and an Alzheimer's disease definition and staging, and that somebody may have both or they only may have one. And this is the formal proposal that was made. That's what I'm finishing up with, this biological definition of neuronal synuclein disease that really makes the case to kind of lump together dementia with Lewy bodies and Parkinson's disease dementia from a clinical standpoint when you're talking about disease from the earliest stages. And I finish up with one last slide that I think sometimes change is necessary, and this is kind of a personal note from the area where I live. So you all should be at least familiar with the name Frederick Lewy, and he's an example of change in his life because he was German. He was a neuropathologist. He was actually in the lab of Alois Alzheimer, working in Alzheimer's lab. And he actually fought for the Germans in World War I. And when Nazism came around in the 1930s, he decided it was time to leave Germany. And he ended up in the United States. And he changed his name. So that's one change he made. He added an E to his name. So Lewy became Lewy. And then he didn't fight for the Germans in World War II, as he had in World War I. He fought for the Americans in World War II. But then the other interesting personal point for me I'll share is, in case any of you are ever interested, this is his grave site, tombstone, and has him and his wife. And the reason I show it is because it's about 5 minutes from my house. He came to the United States. He went to the University of Pennsylvania. He kind of became a pacifist. He joined the Friends community. And he eventually was buried at Haverford Friends School, which is about 5 minutes from my house. And there's a little graveyard attached to the school, and this is his gravestone. So I feel, inspired by his work and, that he did to diagnose the pathology of Parkinson's disease. So I can say that what I'm doing here is someone in honor of someone who's, close to where I live. And I think that's the last slide. So it is, and I will stop sharing. And I'm just back with you all.
Awesome. Well, if anyone has any questions, feel free to drop those in the chat. I know this was a lot of really good information. And one of the questions that I actually had, since they are what appears to be clinically similar, if not the same disease, how does that impact treatment? So treatment around some of the symptoms related to that.
I would say I'll keep referring back to the problem that we have, because I think that's why we need a change. The problem that we have is that there's so much more research in Parkinson's disease and dementia with Lewy bodies. There have been almost no studies in dementia with Lewy bodies. There's 2 clinical trials that are actually wrapping up now for cognition and dementia with Lewy bodies. Prior to that, there really hasn't been any in a long, long time. It's hard to find adequate patient groups because they tend to be spread across memory disorder clinics, movement disorder clinics, primary care clinics. So DLB is just like a really hard disorder to study compared with Parkinson's disease. So therefore, all the treatments that have been developed or tested are almost all in Parkinson's disease. And then we have to kind of wonder if they're going to apply to dementia with Lewy bodies as well. So I would say there that it's when you're treating dementia with Lewy bodies, either cognitively or psychiatrically or motorically, you're really just operating based on your clinical experience more than anything.
This person says, any comment on the psychosis manifestation difference between Parkinson's, dementia, and Lewy body besides any cognitive issues?
Say in terms of presentation, I don't think there really are clear differences. So for both disorders, compared with schizophrenia, where there's psychosis, or compared with Alzheimer's disease, the predominance of hallucinations anyway are visual hallucinations, although we do now appreciate in Parkinson's particularly that other the hallucination can occur in other sensory domains, so auditory, tactile, olfactory. So really any of the senses can generate hallucinations in Parkinson's, but visual hallucinations are the most common. And that's true for dementia with Lewy bodies as well. Delusions, which are fixed false beliefs, can occur in both disorders. I don't really think there's appreciable differences there, and they're less common than hallucinations and tend to happen as the person is more cognitively impaired. That's more likely to happen. I guess the main difference I would say about psychosis is that in Parkinson's disease, to some extent, it's driven by the Parkinson's therapy. So people are taking dopaminergic medications, as we call them, levodopa, dopamine agonist, MAOB inhibitors. All of those can contribute to psychosis. In dementia with Lewy bodies, many patients are not treated for the Parkinson symptoms, or if they are, they're on much lower doses, and it's usually only levodopa. So the contribution of medication to psychosis in dementia with Lewy bodies is much less, at least in terms of the Parkinson's medications.
So we had a question of how do you define dementia? I have seen it defined as an inability to perform ADLs.
So I tend to do this very simply because otherwise it gets too confusing. So there's three main categories that we will use in research for cognitive diagnoses. One is normal cognition, one is mild cognitive impairment, and one is dementia. So normal cognition probably doesn't need to be defined because that's pretty obvious. So what is mild cognitive impairment? So that's showing some recognition by the patient or someone that there's been some change in cognitive abilities compared with their baseline or usual self. In addition, there's some documentation from testing that there is differences compared either with how the person used to be or with similar people, so people of a similar age, education background, for instance. So you can detect that on testing. And then third, that their function is overall intact. So their ability to do what are called instrumental activities of daily living. So the day-to-day activities that require someone to use their cognitive abilities, managing medications, balancing a checkbook, going to a grocery store and following a shopping list and then preparing a meal. These are all activities that require cognitive abilities. So those should be relatively intact. It's when those abilities are lost or impacted in a significant way that a person would meet the criteria for dementia. And typically the cognitive changes that you see in dementia, again, would be more severe, obviously, than the ones you would see in mild cognitive impairment. So the testing is usually worse, and now it's impacting on their day-to-day function. So I'm really just confirming what the person was asking in the question.
We're getting lots of good questions. So this person wants to know, so since similar in nature, but Parkinson's exhibits usually motor issues first, while Lewy body disease exhibits mild cognitive impairment, are there different dopamine neurons in the brain affected, or is it based on degree of alpha-synuclein in the, well, it says in the brain, or in the neurons, but I'll say in the brain.
Yeah, I don't think we really know that for sure. So most of the dopamine imaging that occurs is focused on what's called the nigrostriatal area. There are other dopamine scans that assess the brain more widely, but that's the mid part of the brain that's thought to be most affected and responsible for producing the motor symptoms. That area of the brain does connect more broadly to other parts of the outer part of the brain that are maybe more intimately linked with cognition. So we do know there seems to be some association between that dopamine system and cognition in some ways. I think the clearer link with cognitive impairment comes from the synuclein disease, because that's really what's more easily observable in autopsy. So the presence of these Lewy bodies, you can actually see them, count them, and it's the distribution of Lewy body pathology. Has it spread out of that middle part of the brain to the outer part of the brain in a significant way? And if it has, those are the people that are more likely to have been cognitively impaired while alive. So it seems to be the spread and severity of this Lewy body disease that really drives the cognitive changes when the person is alive.
Okay, I think this is kind of related to that. So this person says, my understanding, research in Alzheimer's disease does not show alpha-synuclein or the Lewy bodies, or is where the alpha-synuclein bodies are clumped in the brain. So I guess they're asking, is it actually something different from alpha-synuclein, or where it is actually deposited in the brain, I think is the question.
I'm not sure of the question, but let me just answer something.
Is that Lewy bodies, because is it clumps of alpha-synuclein, or is it something else that you're seeing in Alzheimer's disease or different places in the brain?
Let me just try to answer something about Alzheimer's, because I got the Alzheimer's part, but I'm not sure I got all the rest of it. So what I will say is that we have a growing appreciation that people often have more than one disease, and that's really most obvious on pathology. At the most recent Movement Disorder Society meeting in Philadelphia a couple months ago, I went to a couple of pathology presentations, and quite often when they look at the brains of people, the likelihood of having more than one disease, like Parkinson's disease and Alzheimer's disease, is quite high on autopsy. Even if it's not severe, just the presence of some of the disease is very common, and there's other diseases as well. We do know from Parkinson's disease that if you have dementia anyway, and you go and you die and go to autopsy, about a third of people will have not only the synuclein disease, but they'll have Alzheimer's disease as well in their brain. Conversely, if you look at Alzheimer's disease, there's been some very interesting research recently that if you just take people who are clinically diagnosed with Alzheimer's disease, about 20% of them have synuclein disease as well. So it just shows again the overlap between these two disorders. We have to probably just stop thinking about these as really distinct disorders, because there's so much overlap. So just calling somebody Parkinson's disease is really probably missing the boat in a fair number of people, because they probably have a second disease as well.
Question about how will other Parkinsonisms be designated, such as PSP, MSA, and cortical basal degeneration?
So in the neuronal synuclein disease, this seems to be specific to what we're calling Parkinson's disease. It's not specific to MSA, which has a different pattern of the synuclein biology and distribution in the brain. So they're trying to develop tests that are really quite specific to Parkinson's disease, and not to these atypical Parkinson's, as they're called, which include MSA, CBD, PSP, and that have a different neurobiology than what we currently call Parkinson's disease. And that seeding amplification assay, synuclein assay, allows us to do that currently.
Okay, so this person says they have a friend with idiopathic RBD and anosmia. They're terrified of developing Parkinson's, but haven't in the past 10 years. Should they be worried about Lewy body disease? Is there anything you can do to prevent a diagnosis?
So I would be worried if I had isolated RBD. I'd be worried. I mean, it's well, I guess the positive things to say is it may take many, many years, and it and it's not universal. I mean, it's near universal based on existing research, but not everyone, not 100%. And I guess the other thing was there's a lot of people that carry a diagnosis of RBD, but may not have had a polysomnogram. So if I was personally diagnosed with RBD, I would want to get a polysomnogram. It's a sleep study that can formally diagnose it accurately, because there's other things that can mimic RBD. So that's what we call a PSG confirmed diagnosis of RBD. In terms of what can be done, well, nothing at this point. You can treat symptomatically the RBD, but in terms of conversion to a disorder, there's studies that have already been done in terms of disease modifying therapies. There's additional studies that are planned in terms of disease modifying therapies, and some of those studies are going to be at the stage of RBD, or as early as possible. So everybody wants to be able to do that, right? To identify people as early as possible, to try to treat them and to prevent the disease from progressing, or at least slowing it down in a meaningful way.
This person wants to know, does a PET scan show DLB differently than a DOT scan?
Yeah, well, there's FDG PET scans that look broadly at function. There's DOPA scans, fluorodopa scans that are PET scans that look at the dopamine system more broadly and in a different way. It's just the SPECT scan is something that's easy to obtain and is very focused just on this one specific part of the nigrostriatal system, it's called, or the dopamine transporter part of the substantia nigra. So it has many advantages over duopa. I mean, not duopa, fluorodopa, which is the PET scan for dopamine. So, but they do measure things similarly. It's just not as practical or easy to do that as it is to do a DAT scan.
So, at the PSG meeting last week, was there any consensus on naming conventions? I heard the discussion last year and have read some of the discussion in the literature.
Not on this topic I'm presenting today, if that's what the question refers to. The PSG was a great meeting, having been there, and Anissa was there. But this topic was not covered. Lots of other topics were. There's an international Lewy body dementia consortium meeting next month in Amsterdam at the end of January. So I'm going to be part of a debate at that meeting. So this topic that I'm talking about today will be a debate. And so I think that's a good venue to kind of air some of these issues, discuss them, because that's a different community. Like I'm used to presenting in the Parkinson's community that are relatively supportive of what I'm proposing. When you go to the dementia with Lewy bodies community, they're less supportive of this because I think they see a threat to the diagnosis of DLB. But I think people are coming around, and if they see that there's a common goal here, and it's not like just to take someone's diagnosis away or turf away, then we hopefully can all work together towards what we want, which is to help identify and treat people.
Well, and I think the more you learn, the more science gives us insights into things, then more clearer names can be given. And that goes along with this one question of what might be a new label for movement disorder specialist compatible with the new proposed diagnostic labels, and noticing that a lot of the symptoms actually aren't movement related or motor related, but non-motor related.
Yeah, so I think that's why we settled. Again, there was lots of discussion, and not everyone agrees that we ended up with the best term, but it was one, the neuronal subnuclein disease. So I think as a group, we envisioned that if this stands the test of time, that one day, it's for research purposes now, but one day, who knows when that day is, we wouldn't be diagnosing Parkinson's disease anymore, or dementia with Lewy bodies, either one. We would diagnose synuclein disease on the basis of the biology, and then kind of classify people under this synuclein disease on the basis of their clinical symptom. And then we could say they have synuclein disease alone, or they have synuclein disease plus Alzheimer's disease. So I think that's kind of was the spirit of this, and the goal of this was to not be wedded to just a clinical diagnosis that has too much inaccuracy built into it.
More around care. So this person wanted to know, what kind of a team would you recommend someone put together for someone older diagnosed with Parkinson's, Lewy body disease, and Alzheimer's disease? And this was diagnosed, I guess, through PET scan and lumbar puncture is what they said.
Well, yeah, that gets into clinical care, and that's a whole different
Yeah.
ball, so to speak. But I mean, I come from settings where I feel fortunate. I mean, we don't really have the multidisciplinary teams formally that we used to, but at least access to many professional groups that are instrumental in the care of patients that are complicated. So for me, that includes a movement disorders neurologist, me as a psychiatrist, sometimes a often a neuropsychologist if an assessment is needed, social work, nursing to support or instead of the physician staff, speech and swallowing experts, for those problems, physical therapy for typically gait and balance problems, occupational therapy for kind of typically upper motor issues. Um, I'm forgetting there's other groups as well, but it really, you potentially need access to a lot of professionals to provide appropriate care.
No, I think that's very helpful. Well, I think that we covered the majority of the questions, and this was, very helpful. I think, again, it's still a very confusing two symptom or two diagnoses, but the fact that we're even having the conversation around the fact that that is the case, and is there a place for unifying that diagnosis is great that we've gotten to that point. So thank you for sharing that and also for debating it.
You're welcome, and I agree it's confusing, which is why it would be good if we had an alternative moving forward.
And I will say a comment that came in that just said this presentation has answered so many questions for us and confirmed some of our positions. So it's very helpful.
Thank
So
you for
thank you so
feedback.
much, Dr. Weintraub. I want to thank everyone that joined in, all the wonderful questions. Reagan just dropped the link in. I think earlier, if you want to go back and watch the recording, you can see the slides there. Please go back and do that. And in PMD Alliance style, I would love to invite everyone to thank Dr. Weintraub with a wave of gratitude. So thank you so much for joining
Thank you.
us.
You're welcome, and happy holidays to everyone.
Same to you. And thank you, everyone. And I hope you have a great rest of your day.
Bye.